And welcome, I'm Dr. Deuk here at the Deuk Spine Institute. We are getting ready to perform spine surgery live for you, broadcasted over the internet. Little injection, we're giving the patient some numbing medicine. This patient has chronic back pain and pain into both legs. We'll be performing a procedure on the disc herniations that he has to treat back pain and leg symptoms. Left L4-5 and bilateral L5-S1. We're also going to be performing a treatment for his facet joints. And what does that mean? Well, the disc is not the only joint in the spine. Many patients have facet joint problems. I need a little num-num. The facet joint is a joint located in the back of the spine. And Henry, why don't you show our audience all the different causes of chronic back pain? What are the possibilities? There are 30, folks. I'm Dr. R. Deuk with the Deuk Spine Institute, and we're going to discuss of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Deuk Spine or Deuk Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies. With trauma, can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk. Thanks for joining us. Welcome back. Now you can see why diagnosing chronic back pain is so difficult for most doctors, because there's so many potential causes. But at Deuk Spine, we've developed a system for diagnosing back pain very quickly and very accurately. This patient, we diagnosed him with back pain from different sources, specifically his L4-5 facet joint, which you just saw what that was, L5-S1, both sides. So that's 1, 2, 3, 4, plus 2 discs, 5, 6. So he has 6 causes of chronic lower back pain. I've seen patients with 15 causes, everywhere from 1 to 15. I haven't seen anybody with more than 15. That said, we believe his pain is coming from 2 discs and 4 facets. We're going to fix all of these 6 areas today. All right, any questions, Henry?
At this moment, no current questions.
All right, well, without further ado, we're going to get started. First by placing our needles at the L4-5, and then I'm going to finish the L5-S1. How is he?
How you doing, my friend? You okay?
Shot?
You all right? Can you open your eyes for me? How are you? Can you open your eyes for me? Good. I'm going to ask you some questions, okay?
Yeah. Shot? All right, what do we hung up on there? Any questions from our audience, Henry?
At this moment, no current questions.
Let's get an AP, see where we are. Our 2 needles on the left are perfect, and I want to make sure my right needle becomes perfect before we advance it. Yeah, it looks damn good. Again, this is the ninja attack. Rather than a giant scalpel, folks, we're using a laser and, well, needles. I'm encountering a lot of bone here. Interesting. I don't know why. He's not had prior back surgery, right? No. Oh, there we go. Little progress. Interesting. Well, he's calcifying. Oh, there. Let's see if we're in the disc there. Do you have any?
How you doing, my friend? Can you open your eyes for me? Good. We're going to ask you some questions, all right? Don't move. You all right?
It looks like
You doing
this.
okay?
Give me an AP. Yeah, we're going to verify an AP. It looks like the dye's in the disc on the lateral. Yep, we're in the disc on the AP too. Look at that, dye's in the middle. So when you have 2 views, when you're using a biplanar technique to verify in surgery, you need more than two-dimensional information. We're dealing with 3-dimensional structure, so you have to go with a different plane.
You okay?
And we did.
Can you open your eyes?
Time to wake up!
Wake up. Open your eyes for me. We're going to ask you some questions, all right?
All right, lay still. We don't need you moving around. We just need you awake.
Don't
You're doing great. Can you hear me? You having any pain?
Are you having any pain, sir? Yes or no? You having any pain?
How bad is that on a scale of 1 to 10? Shot. Look at that tear. It's humongous.
Give us a number.
Yeah.
Give us a number. 1 to 10? What number?
10. Okay, I heard 10. All right, we got a 10 out of 10 at 5.1 and a 9 out of 10 at 4.5. That woke him up. So the patient is sensitive to sleepy medicine because, well, he's a clean guy, and it took us a little while to get him awake, but he is awake. We're going to put him back to sleep now. All right. We'll get started with the L5-S1. Any questions, Henry?
At this moment, no current questions.
Let's show our audience then we've already shown them how these discs can be so painful, right?
Of course, the 30 causes of back pain, we showed that, yes.
Well, no, that was the inflammation of the disc or discogenic back pain, right?
No, we have not shown those.
Let's do that.
Copy that?
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
All right, welcome back. Dr. Deuk Majin here. And you've just seen how disc herniations can cause pain. And boy, can they be painful. Anybody with chronic back pain from a disc herniation can tell you just how severe the pain can be. We are now about to enter the L5-S1 disc on the left side using our dilator. The dilator is a very nice piece of equipment. It does not cut anything, it just spreads things. And as such, it's a great, it's a great tool. Hold on. Is there any way we can get the image up on the big board?
Can you press over there to change it or?
Let's have that back. I just don't trust it. And if we're having an ongoing issue with projecting to the TV, we should get our IT network company to fix this for us, okay? Jordan, Henry, somebody?
Sir.
Maybe you can
Yes.
talk to Chris. Shot.
Hit it, Jordan. There you go.
Mm-hmm. Shot. Shot. Looks good. Sorry you guys cannot see the x-ray. We're having an issue with transmitting those images to you. However, we can see it here in the operating room using our fluoro machines monitor. And so far everything is going really well for this patient. Dr. Berndes is happy because we like patients that are sensitive to our medicines. Right, B? Because then we don't have to load them up with so much. Better. That's fine.
Laser ready, please.
We got the response we needed.
Yeah. Right here. Come. Press that up. Use up. All the way to 3.
Any questions, Henry?
At this moment, no current questions.
Then let's show our audience why do we do the Deuk laser disc repair for herniated discs.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
We need that stripper. Welcome back. You can see what we're doing with the Deuk laser disc repair. We're using a laser to clean out the tear in the back of the disc that's causing pain. Oh, yeah. A what? In the morning? What is he? Really? I guess tomorrow's his last day here. For those of you who are familiar with the surgery, you understand the blue fiber is plastic around a glass fiber. The glass fiber itself is what carries the laser energy to the disc for the repair. All right, yeah. Excellent. Any questions, Henry?
At this moment, no current questions.
Thanks. We played the 30 causes of chronic back pain.
Correct.
A lot of scar tissue is what I'm seeing. This means there's been a lot of inflammation for many years in this particular disc. This again is the L5-S1 disc, and it's on the patient's left side. We're doing both side L5-S1 because the patient has, honestly, a tear and herniation on both sides. And that is something that happens in a lot of patients where their herniation will be on both sides of the spine, affecting the nerves leaving on both sides of the spine. So if you only fix the left side, then you're only going to get improvement on the left leg. And if you fix the right side, you'll get improvement on the right leg. So some people actually need both sides operated on. All right, it's been a long day, and I just want to thank everybody for doing such an amazing job all the way to the end. This is our last surgery for today. This patient has been very patient, patiently waiting, and we appreciate that. No one ever wants to be last, but the truth is our last patients are always our healthiest patients. We take the sick and feeble before. The more complicated anesthetic patients before. So far, so good. This is inside the tear at L5-S1. This is all herniation right here. We're removing this herniation with the laser, just as you saw in the video. Henry, would you say the video is a very good representation?
I very much so believe so, that it works really well. There's it's detailed, it's just intricate and very compelling, and so I'm very proud of it, and I hope everybody else feels the same.
Yeah. All right. If you have questions, feel free to type them up. We like to answer questions.
We do have a question. This is coming from Rita on YouTube.
Rita, had to get a question in every surgery today, right, Rita?
And they asked, if there is a lot of tissue inflammation and the disc is really bad, what then? And also, thank you, doctor, and all for a lot of information. You guys are awesome. Hope you get to relax tonight.
Yeah, first of all, thank you. But I heard the part about if there's a lot of inflammation in the tissue, and then I didn't really understand the question. What was the question exactly?
Yes, they said if there's a lot of tissue inflammation and the disc is really bad, what then?
No, the procedure still works. The disc cannot be so bad that this procedure doesn't work. There's no such thing. As long as I can get to the disc, I can repair it. And the only thing that's going to keep me from getting to a disc is something other than the disc. Okay? Like an abnormal facet joint that's too big and it's grown out sideways and it's pushing my needle away from the disc so I can't get to the disc. Or like in the last case where there's a fusion the patient had and the bone mass is so big, not the last one but the one before, where the bone graft and bone mass fusion mass is too big and it keeps me from getting to the disc. So those are the only ways that we can't fix a disc. Doesn't matter how much inflammation, how much degeneration the disc has, we can fix it. Okay? There's nothing that limits our ability to fix a painful disc. If you have back pain, chronic back pain, there's an 85% chance it is the disc. A disc or two discs or three discs that are causing it. If that's the case, this is the surgery that is the best. There's no better surgery in the world. And there's nothing that will stop this surgery from working as long as you have discogenic pain, except not being able to get to the disc. And I've had a couple of situations like that where I cannot get to the disc because of what's called anatomical constraints. Okay, anatomical constraints. Hold the tube. In those certain cases where we have anatomical constraint, sometimes the patient will have ongoing issues with that level that I couldn't treat, but the vast majority of the time we never have a problem because the anatomical constraints that prevent me from getting into the disc to fix it are the same things that actually end up stabilizing the disc. So for example, an abnormally large facet joint is also going to be more stabilizing than a smaller facet joint. But because it's a big joint, it keeps me from getting in to fix the disc. But because it's a big joint, it also stabilizes the segment better. So it's actually a situation where if you can't do it, then maybe it wasn't meant to be done, if that makes sense. The patients aren't left in pain. Their pain actually goes away because we were still able to treat the areas that were causing pain. I've never had a surgery where I went in and couldn't get rid of pain in a patient. Our worst outcome ever is like 80% elimination of pain, disc pain. I mean, in the last 5 years, our worst outcome with the Deuk laser disc repair for disc pain was 90%. 90%. Our average was 99.6%. That's 100%, basically. So we've gotten really good at identifying disc pain and treating disc pain at Deuk Spine. Nobody else in the world gets rid of 99.6% of pain. That's 100%, rounded up. No. All right, this is the last minute or two of 5-1 on the left. You can see just how degenerated the disc is here. Whoop. This is I'm trying to get over as much as I can. You can see the blue, that's all herniation. And that's staining. I'm just trying to get rid of as much of that as I can. We never get 100%. So don't ever expect me to get 100%. It's not going to happen. I never tell anybody I'll get 100%. I tell people the truth, which is the average is around 60% for my treatments, but you need 50% to get good symptom relief. And like I said, we don't have situations where we don't get that. All right.
We have a couple questions.
All right, give me a second. Yeah, I'll take the question.
No problem. This next one coming from...
We're in the more sensitive area right now, Dr. B, so he may respond. Go ahead, Henry.
This next question coming from Running Myself Raw on YouTube. Asking, what if the nerve is being pushed on by a bony growth or thickened ligaments?
What if the nerve is being pushed on by a bony growth or thickened ligaments?
Correct.
Well, it's really a misleading question, all right? And the real question should be, what if a bony growth or thickened ligament is what's causing my symptoms of a pinched nerve? That's the right way to ask the question. And the reason that's the right way is because what you've asked me is, what if their bony growth and thickened ligament is pushing on the nerve? But what if that's not causing any symptoms? That's my response to you. Okay, you're saying, what if there's a bony growth and thickened ligament pushing on my nerve? My answer to you is, well, they're not causing your symptoms. If your response to me is, yes, they are causing my symptoms, 100%, God's witness, then I would say, then you have to have those fixed. But I never see that. In my treating 100,000 patients, I don't see that. So either somebody has lied to you about what's causing your symptoms, or you're lying to yourself about what's causing your symptoms. But I don't think it's those things causing your symptoms. So the question you're asking me is misleading, because it's saying, Dr. Deuk, wouldn't you want to treat the thickened ligament? No, I don't. You know how many times I've treated thickened ligament? 0. And how many of my patients have I fixed? 100%. So you're the one who's wrong. I'm the one who's right. You have a example of one yourself, which is misled, and I have an example of 100,000 people. That's what I would say to you. I always have people out there who are like, how could your laser surgery work for everything? What if I have a bone spur and thickened ligament? You're not treating that. You're right, I'm not. But my laser surgery still works. So you go figure that logic out. I don't engage in arguments and debates with people on internet because there's no point. You could not possibly have the knowledge and experience that I do. And so for you to challenge my knowledge and experience is silly. And I won't even engage people like that. But you've crafted the question in such a way that you're trying to entrap me into an answer that you want to hear. And I'm not going to play that game. There's an old saying, homie, don't play that. Go look up Living Color and you'll see who I'm talking about. Homie, don't play that. Homie the clown, don't play that. All right. We're done with one. We're moving on to the next. It's like, first of all, I don't believe in ghosts, all right? I'm just going to get that out right now. I don't think that's political, and I'm allowed to talk about things that are not political. I don't believe in ghosts. So that would be like me saying I don't believe in ghosts, and then somebody says, Dr. Deuk, what weapon would you use to kill a ghost? And it's like, well, first of all, I don't believe in ghosts, right? So why would I have to have a weapon to kill a ghost when there's no such thing as ghosts? All right, that's the kind of question they're asking me, is like, what would you do for bone spur and ligament pushing on the nerve. Well, that's not the problem, my friend. The problem is you don't have the right diagnosis. Now, there is a chance I'm wrong about this. I'm willing to concede that. Next question.
Next question coming from Rita once more on YouTube, asking, do you show knee procedures also?
Knee procedures.
Correct.
Yeah, we could. Rita, we don't usually, but we could for you. I'm just kidding. Of course we have knee procedures. They're on our YouTube channel, right, Henry?
Correct.
Rita, go to our YouTube channel, DeukSpine.com, or Deuk Spine, whatever it is on YouTube, and look up Deuk Plasma Rhizotomy Knee. Thanks for fixing that, guys. Wait, let me see. Yeah. We got the x-ray thing working again.
Yep. We're right on it.
What was the issue? Do you know, Jordan?
I just swapped the boxes.
So you think the box is bad? You think it's bad or sensitive?
I think it's just sensitive.
Should we buy a new one?
I think we.
Luis, get a new one.
Okay.
Wait, I gotta put the dilator in. Guys, I can't have these boxes failing during surgery. Let's buy the right one. Talk to our land tech and see what it is.
Good.
Yeah, we're good. This is a big tear at 4-5 on the left. I think this was causing him a lot of pain. So I think he's gonna be happy we're fixing this one. That tube went in very easily, by the way, which means the tear is huge. All right, what's the next question? Did we turn the scope off in between those discs?
Yes.
You just turned it back on?
Yes,
Thank you. I just looked over and the light was on. I'm thinking, did we turn that light off? Henry, any more questions?
No current questions, but we do have a comment from Running Myself Raw on once more on YouTube saying, wasn't playing a game, simply just asking if the surgery would work with the diagnosis that I got.
Well, all right, Running Yourself Raw. Fine, I'll accept that. But I will tell you this. That's not your diagnosis. And I want to take a moment to just digress. The word diagnosis is often misunderstood. Okay? What is a diagnosis? A diagnosis is basically the cause of a abnormal medical condition. And in my opinion, the bone spur and the ligament thickening is not the cause of your abnormal medical condition. So there's a difference between diagnosis and finding. Do you have thickened ligament? Yes, I'm sure you do. I'm not challenging that. Do you have a bone spur? Yes, I'm sure you have a bone spur. I'm not challenging that. Are those findings? Yes, they're findings on your MRI, CAT scan, X-ray, whatever it is you got. Okay, I don't challenge any of that. That's probably all true. What I'm challenging is that that's the cause of your symptoms or your medical problem, because I don't believe it is. That's what I'm saying. Therefore, I'm going to defer answering whether my treatment would work to fix your problem, your diagnosis, because you have the wrong diagnosis, in my opinion. Now, I could be wrong, but I'm extremely rarely wrong about something like this. Doesn't mean I can't be. Here's what I would do if I were you. If you really want to know why you're having pain, do our free MRI review. Let me see you for free. Let me examine you on Zoom for free. Let me review your MRI for free. Let me review your history for free. Let me talk to you for free. Let me give you your diagnosis, your real diagnosis, for free. And then, if you like all that, you can come here and get fixed with this surgery. That's what I would advise to you. All right. So far, everything is going really good for this patient. We're not having any anesthesia issues or any surgical issues. There's a lot of pieces of herniation here. And I'm just reaching in with this grabber to pull them out. Some of them will come out easily, some will not. The ones that don't come out easily are stuck. And they're stuck with scar tissue that's created from inflammation. Oh, by the way, almost every patient I do this surgery on has thickened ligaments and bone spurs. And we don't touch the thickened ligament. We don't touch the bone spurs. Okay? We just do this surgery. And lo and behold, miracle of miracles, their pain is gone. And you know why? Because the ligament that's thickened and the spurs have nothing to do with it. They're just innocent bystanders. All right. So I know we had a long day today, but we have another long day tomorrow, and then everybody gets a break. So tomorrow our first case will be a Deuk laser disc repair, cervical. Patient's coming from Singapore. She has 2 herniated discs in her neck along with facet joint pain. We're going to do a DPR on her facets, we're going to do a DLDR on her discs, and then we're going to be done with her. We'll move on to patient number 2. Second patient has 2 herniated discs in her neck. We'll be doing cervical Deuk laser disc repair as well. We've been doing a lot of cervicals lately. We've even done a lot of thoracics. Today we did a thoracic. That patient has no more thoracic pain. And we did a thoracic yesterday, and that patient has no more thoracic pain. He was from, where was he from, Henry?
Good
did
question.
A testimonial.
Yes, Trinidad.
No, Trinidad was lumbar.
Oh, I apologize.
He was a thoracic. Wasn't he like New York or
I think it was New York.
New York or New Jersey?
Yeah, I apologize. I'm looking that up right now.
Yeah. Oh, Trinidad was cervical. You're right. I apologize. But the thoracic yesterday, single Puerto Rico. That's it.
Puerto Rico. Apologies.
Yeah. Boy, I'm having to remember all these different countries. Any other questions?
At this moment, no current questions.
Luis, the film team received your box of goodies.
Oh, good.
They told me to tell you thank you so much. They're perfect. They love them.
Oh, good.
And they are halfway done with filming the movie.
Good.
So, yeah, actually, when the movie's done, we're going to have a movie night. All right. Henry, what do you think about a movie night?
I love that idea. That sounds amazing.
Yeah,
Like a premiere kind of thing.
I think that's a great idea.
Yeah.
Cervical DPR. Yeah, she's actually doing really well. You mean the last case?
Yeah, last case of the day.
Yeah, her only complaint today was jaw pain, ear pain, and she has TMJ. So I'm giving her a TMJ injection tomorrow. At least I'm not, Patel is, but I don't know. She doesn't seem to have C1, C2 pain. I looked at her CAT scan. I don't see any arthritis at C1, C2. So I'm hoping it's all gone now that we've done the 2-3, C2-3. You know, I'm hoping it was all C2-3 because it was definitely C. Huh? Yeah, I hope to God she didn't need that fusion. She is, but I really don't want to do a fusion on her. She had a Chiari decompression. I looked at her CAT scan. They drilled away the base of her skull to decompress the cerebellar tonsils and the brainstem. And then I'm sure they did a dural patch graft. That's what we used to do when I did them. And it's a very hard area, very high risk. Got your. No. I do all mine prone. Yeah, you can do sitting if you want, but there's no reason to. The safest, best way to do it is prone. But you're right, people do cranies differently. Oh, sitting cranie is how we used to do it a long time ago. But the more advanced treatments are 3/4 prone and prone. And for this C1, C2 fusion, we do it prone. I've done a lot of C1, C2s. Look at that inflammatory tissue. Pink. We're almost done here. I got about another 2 minutes and we're gonna go to the other side, finish up, and then we'll just do the DPR, which will be pretty quick. So far, what I'm finding is that these discs, this is the L4-5, a lot worse damage than I expected based on the MRI. The MRI didn't look as bad, but being inside the disc, I can clearly see there's more damage than the MRI showed. That's the problem with MRIs, folks. Number one, they don't tell you where pain comes from. Number two, they don't really show quite the extent of damage. Any other questions, Henry?
At this moment, no current questions.
All right, here's the outside of the disc. We've pulled ourselves from inside all the way through the tear to the outside. We've been zapping away the herniation all along the way with the laser. You can see a few pieces. And whoever had the thickened ligament bone spur issue, you know, he exemplifies what's happening right now with patients with back pain. They go see a doctor. The doctor, if they're a pain management doctor, they want to do the mild procedure. So look at that little bit of inflammation on that piece of disc hernia. You guys see that? Inflammation on that piece of herniation right there?
Yes, we do.
That's insane. It's like a little fish flopping around trying to get out, and it's got inflammation on it. That's so cool. Anyway, we'll help it out. So what happens is you go to your doctor, and if the doctor is a pain management doctor, their highest yielding surgery is the mild procedure. They make a lot of money. But you only do the mild procedure if you have a thickened ligament. So they diagnose the patient with a thickened ligament. And of course, who doesn't have a thickened ligament? Everybody does, right? By the time you hit like 35, everyone's got a thickened ligament. But they're basically giving the diagnosis that allows them to do the highest paying procedure they can do. And then the bone spur is, you got a bone spur, that's the safety net of if my mild procedure doesn't work, which is not going to work, by the way, then you gotta have to have a fusion done. And we do this special fusion called an interspinous fusion. So it's basically just a sham scam. And these patients are getting suckered into this stuff. And they're getting all these treatments that don't work and are they're getting convinced to do it because they're pointing out the thickened ligament or the bone spur. And I feel bad for the patients because they don't know any better. You know, they're trusting their doctor, telling them the right thing. And the doctors really don't know any better. They're trusting the implant company that sells the mild implants or the mild disposable tray. It makes a lot of money when they do those procedures. So it's just a system that's broken, feeding on itself at the patient's expense. All right, that was the hole, guys, where the herniation came out of. See it?
Yes, we do.
Looks like a man going, oh, right? Anyway, I've got a great imagination. That said, it's going to close off. Now remember, this fiber is 1 millimeter. Look how big the hole is. It's about 3 millimeters. So it used to be 7, now it's 3. Okay, it's going to close very quickly. The nerve root is over there somewhere in that fat. I'm not going to mess with it. All right, no reason to. But we're done with left side. We got the right side to do next. So now that I've taken the herniation out of it, it will seal. But it takes 9 months to fully seal. 9 months. I wish I could speed, I need the dilator. I wish I could speed it up, but I cannot. I'm going to switch sides. It's a good thing we did 4-5, right? The MRI shows 5-1 to be really bad, but 4-5 is nowhere near as bad, but I'm glad we did it because it was painful. All right. Come on in, Jordan. Whenever you're ready. You want a num-num again? Another 7 millimeter incision. If you have questions, feel free to ask them. Go ahead, Jordan.
No current questions, so we do have a comment from Rita, once more on YouTube,
Sure, Rita.
saying, my pain doctor doesn't do surgery, just injections as far as I know. That's part of my problem. Nobody wants me to have surgery, but I won't give up.
Rita, yeah, pain doctors aren't supposed to do surgery, but that has not stopped them from doing surgery. In the last 10 years, I've seen more pain doctors doing surgery than I see surgeons doing surgery. And that, I mean, pain doctors never did surgery. But what's happened is the companies have developed these surgeries, little minor surgeries that are so minor that surgeons say, well, that's minor surgery. And not enough spine surgeons are doing these minor surgeries that they're not happy about. So they're looking for someone else who can do that surgery and use their product, because they're going to make, you know, $5,000-$10,000 every time someone does their surgery with their product, right? So for example, if I was the company that does the mild, they sell the mild surgery, M-I-L-D, okay? And I sell that mild kit to a surgeon or a hospital for $5,000. Well, I need surgeons to use it. And if surgeons won't use it because they're doing fusions, then I'm going to find somebody else to use it. And that's exactly what's happened. And they're now pushing pain management doctors to do these procedures that don't work, that make these companies a lot of money, but don't benefit the patients. Shot? And so, in the end, the procedures, these surgeries are being done by non-surgeons, and they call them procedures rather than surgeries, even though they are a surgery because you're making an incision. It's just a very messed up system we have right now. And it's all driven by greed. It's not for the patient, not to make the patient better. when medicine is supposed to be about making the patient better. Okay? My father was a doctor, and a very good one at that. Hold on, go ahead and take it out. And my father taught me you go to medicine to help patients. That's why you go to medicine. You do what's right for the patient. But unfortunately, in the last 15, 20 years, that's all changed. And doctors who aren't supposed to be doing surgery are now doing surgery even though they weren't trained to do surgery. They're not surgeons. But surgery pays better than needle procedures. A needle procedure pays $50 profit. Surgery can make $1,000 profit. That's what's driving these pain doctors to do surgeries, is greed. They want the big payment that the surgeons are supposed to get for all the years. That's what happened, Jordan. Now I understand.
This option, please. Thank you.
Jordan, you've been a bad, bad boy. Just kidding, Jordan. All right, we are on our last disc. Last disc of the day. We should do something about the last disc of the day. Like a trivia or a potluck. Last disc of the day potluck. How you like that, Henry?
I love that idea. That's amazing.
Last disc of the day potluck. I don't know, there's something funny about that. Okay, any questions?
No current questions, but we do have a comment coming from Brian on YouTube
Rock and roll, Brian.
saying pain doctors do stims and pumps, meaning big money.
Yeah, you're right, Brian. 100% right, Brian. You are 100% right. That's what I've been saying for years. The stimulators and the pumps are making them millions of dollars in profit, and they shouldn't be doing them, and they're overdoing them on everybody. And I don't know, who's Brian? Is Brian a real person?
I believe so. Brian S. on YouTube.
I think I know who Brian S. is. Because Brian S. is just too in tune with the universe. Sounds like he might be a Princeton student. Is Brian S. a Princeton student?
Arias is shaking his head no.
Oh, all right. All right, very good. Well, Brian, you are correct. Average profit for a stimulator is over $10,000 per surgery. And the pain doctors who never put stimulators in before, they're always done by neurosurgeons. In the past, when I did my training, it was a neurosurgery procedure. Patients were referred to neurosurgery by pain, and neurosurgeons put them in. And we would put them in only for end-stage chronic radiculopathy that had no other cure, and peripheral neuropathy that had no other cure. And we would do very rarely, a few a year. Now, pain doctors are doing thousands a year in their practices. And they're racking in the money. And the patients are the ones suffering. Yeah, so Brian, I'm trying to raise awareness about that. I'm glad you already know that. But it doesn't stop with pain pumps and stimulators. It goes on to mild procedure, interspinous devices, intercept procedure, barricade device. I mean, the list goes on and on. There's so many of these scam devices out there now that everybody's like disc seal. I mean, you name it. There's tons. Stem cell, PRP. They don't work for the spine. They never have. They never will. But they won't tell you that when they sell you on it. And that's the problem. There's nothing wrong with trying to fix someone's pain. But if you know it's not going to work, don't do it. All right. Any other comments or questions?
Comment from Brian once more on YouTube saying, real life student, I have a stim myself, Vivex, etc., etc.
I'm sorry, man. I really am. Hopefully someday I can fix you and we can get rid of your stimulator. All right. Well, this is the right 5-1. You can see how degenerated the disc is. That's kind of cool right there, a little band of scar tissue. You see that? And there's the
Yes, we do.
inflammation right there. That's what we're here for, right there. You get rid of that, you get rid of the back pain. Why is that there? Well, we showed you the video earlier. Herniated disc, which is this chunky stuff right here, causes the body to react, making inflammation. And that's what happens. You get all that red stuff. And that's what causes pain. Because that inflammation tissue has little nerve fibers in it. They're called type C, class 4 basically, nerve fibers, which are unmyelinated pain fibers. And all they do is transmit pain to your brain, nothing else. So you kill those pain fibers with the laser, get rid of the herniation, the source of the inflammation, and that's how you fix the problem. You don't need fusion. You don't need artificial disc. You just need to get rid of the source of inflammation and pain. It's all natural, by the way. The surgery you're watching is a natural surgery. We don't put any implants in your body. Okay, we're not putting any junk in there. Nothing unnatural. All natural surgery. All right, we have 1 minute. We're done. We're going to move on to the facets. And we're going to end the broadcast. We're going to come back for one more short surgery. It's the Deuk plasma rhizotomy. We'll be treating this patient's L5-S1 facet joints because he has facet joint pain. Remember the 30 causes of back pain video we showed earlier? Go back and rewind this, and you can see the facet joints are the number 2 cause of chronic back pain. By the way, that's a bone spur my laser just ate through like a excavator through dirt. Okay, huge bone spur. Remember, we don't need get rid of all the bone spurs, just the ones that are pinching nerves. All right, I'm happy. You happy, Luis? Everybody happy?
I'm happy.
Happy with Pappy?
Happy Pappy.
Wow, what a day. All right. Thanks for joining us. We're going to end the stream and come back for one last shindig. I should call it a facet dig. Come on in. It's really not a shindig, it's a back dig, right? Oh, people don't think my jokes are funny anymore?
It's a back dig. I was agreeing.
I'm going to have to fire everybody here and get new staff. Luis thought that was funny. Oh, okay. I see where we're going here. All right. End it, Henry. Let's go.
Copy that. Ending broadcast.